Hello, everyone. Bonjour. I'm pleased to welcome you all to today's Policymakers webinar entitled Virtual Mental Health Services Post-COVID-19, hosted by the Graham Beck Foundation. My name is Alana Ledman, and for those of you who don't know, I'm the Vice President at the Graham Beck Foundation, and I will be the moderator for today's session. I'd like to begin by acknowledging that although we are each calling in from different parts of this country, and some of us from around the world, I'm situated on the traditional territory of the Ganakahaka, a place which has long served as a site of meeting and exchange amongst nations. As we begin this meeting, I'd like to recognize and offer my respect to the traditional custodians of the lands and waters from coast to coast to coast. Je voudrais aussi dire bienvenue à nos partenaires francophones qui se joignent à nous aujourd'hui. For those of you who don't know, the Graham Beck Foundation, or GBF, is a Montreal-based private family foundation working to transform and improve access to mental health and addiction services. GBF has played a major role in catalyzing and supporting integrated youth services across the country. We also prioritize collaboration and knowledge exchange across Canada and internationally, including through the International Alliance for Mental Health Research Funders. As some of you know, GBF has hosted an annual policymakers workshop for the last 9 years. Like so many activities, we shifted to an online webinar last year. For this year's webinar, we decided that the topic of virtual mental health services post-COVID-19 seemed fitting as we are all planning for a post-pandemic era. As you know, e-mental health and virtual care were gaining momentum across the country prior to the pandemic. However, during the last 15 months, almost all of our services have moved online. We thought that this was an opportune time to explore what virtual care might look like when our cities, towns, and communities open again to in-person services. Through this session, we aim to highlight examples of the integration of virtual and in-person services, explore some lessons learned, spark debate about finding the right balance, ultimately discuss what we will need to improve the mental health and well-being of Canadians moving forward. We hope that you will leave this session with some ideas that can inform your work. The format for today's webinar will be as follows. Each of the speakers will give a brief 10-minute presentation. This will be followed by a panel discussion and a Q&A session where you'll have the opportunity to ask questions and make comments. Before we begin, just a few housekeeping items. We ask that you please make sure you're on mute during this session. We also encourage you to ask questions or make comments in the chat function. Please make sure that you select everyone when posting your questions so that all attendees and speakers can see what you write. During the Q&A session, you can also indicate in the chat that you would like to ask a question or make a comment, and we will invite you to do so. Je désire aussi signaler que même si cette session se déroulera en anglais, je vous encourage à poser des questions ou à écrire des commentaires en français. Please note that the session is being recorded and will be shared at a later date. As I introduce our speakers, I would like to encourage you all to introduce yourself in the chat and share where you are calling in from today. As you likely know from the material that was sent out ahead of time, we have 4 wonderful, diverse speakers. First, we will hear from Dr. Shalini Lal, who wears many hats, including the Canada Research Chair in Innovation and Technology for Youth Mental Health Services. She's also a tenured associate professor at the University of Montreal in the Faculty of Medicine, and she's the director of the Youth and Mental Health Technology Lab. Next, you will hear from Dr. David Clark, who is a professor of experimental psychology at the University of Oxford. He is one of the architects of UK's Improving Access to Psychological Therapies program, IAPT, which currently treats over 600,000 people with depression or anxiety disorders each year and reports clinical outcomes on almost everyone. Then you'll hear from Dr. Steve Mathias, who is a psychiatrist and the executive director of Foundry. Foundry is BC's integrated youth service initiative with 19 sites across the province. Last year, Foundry launched virtual care across the province, which provides counseling, peer and family support, and primary care for young people ages 12 to 24 online. Most recently, Foundry launched an app to help young people access services and resources and manage their information online. Last but not least, you'll hear from Daphne Hutt-McLeod, who is the Director of Bustasoni's Mental Health Services in Nova Scotia. Daphne has worked with First Nation children and youth for over 30 years and volunteers with many community projects, board of directors, and communities. Daphne has also co-authored multiple research publications. I will now turn it over to Dr. Shalini Lal to give an overview of the Canadian policy landscape. Thank you for joining us today.
Okay, so thank you for the introduction and to the Graham Beck Foundation for its audacious leadership in bringing together this esteemed group of audience members and panelists to discuss the important topic of technology and mental health service delivery. And I'm going to start my timer on just to make sure I stay in my 10-minute zone. So as a Canada Research Chair in Innovation and Technology for Youth Mental Health Services, which is a title awarded through a program funded by the Government of Canada, my role is to lead applied research innovation projects that leverage technology to improve the mental health and well-being of Canadians. It's also the mission of the chair to advance knowledge and reflection in this field, and thus having the platform of today's event with all these great people here to speak on the topic is very much appreciated, and I very much looking forward to the discussion amongst the panelists and with the audience members. So as the first speaker for today, my objective is to provide a bit of a background introduction to the topic that we'll be discussing today, and also to speak a bit from that perspective of policy. So let's get started. Leveraging technology such as websites, portals, smartphones, and apps to improve access and quality of mental health services, information, and supports is a global priority. This is especially true in the context of the COVID-19 pandemic, given the physical distancing guidelines. But I would also say that this was true even before the pandemic. We know that before the pandemic, there was already a significant gap in terms of the mental health needs of the population and the accessibility of services to meet those needs. Our traditional models of delivering care, such as relying heavily on in-person approaches by mental health professionals, was insufficient and I would say even inefficient in meeting the needs of the population, including addressing the many barriers that individuals face in accessing care, such as stigma, geographical distance, physical disability, limited human resources, to name a few. So it's not surprising that with the rapid advances of technology, especially in the past 2 decades, a new paradigm for delivering care was starting to be recognized and researched for its ability to improve access and quality of mental health services. Next slide, please. We now know that technology can serve multiple purposes and help to make better use of our human resources. Technology can support, for example, the referral process, provide access to evidence-based information that can be both standardized and tailored, provide screening and assessment, support self-management tools, provide access to peer support, cognitive behavioral therapy, and so on. And so with this backdrop of the ubiquitous role of technology in today's society, we can switch to the next slide, please. So with this ubiquitous role of technology in today's society and its potential in addressing many of the limitations of traditional models of care, it begs the question, why is the use of technology not well integrated in our mental health care system? Why is it that in 2021, Canadians can seamlessly shop online, but can't go online and refer themselves directly to a public mental health care organization in their community without having to repeat their story to multiple providers along their pathway to care, without having their referrals lost in the system or having to wait for days, weeks, or even months before they are contacted by a mental health professional? Why is it that in Canada, mental health providers are still relying on fax, paper, and phone-based methods to receive, keep track of, and communicate about referrals? Why is it that a Canadian needs to be lucky enough to live in Saskatchewan to get free access to evidence-based, internet-based cognitive behavioral therapy for the treatment of anxiety, or be in Montreal to get access to specialized online services to support them in their recovery process from a psychotic disorder? How come healthcare students are not receiving comprehensive education on how to effectively leverage the use of technology to deliver mental health services as part of their core curriculum? Why is it that many mental health care providers delivering services for schizophrenia, eating disorders, major depression, and so forth are at best using video conferencing solutions to connect with patients? And this mainly because of pressures encountered due to the public health guidelines imposed recently by that pandemic. In fact, for many countries, including Canada, while there is the existence of a maze of websites providing mental health information for the population to navigate through, and an app epidemic of the development and availability of apps based on false claims and limited evaluation, the integrated use of technology in the mental health care system is still relatively new paradigm, with the current state of funding, research, and implementation being fairly fragmented, even in the context of the pandemic. I believe, at least in part, this is due to policy at the federal, provincial, regional, and organizational levels of care. And more specifically, I'm referring to mental health policy and the limited priority or role given to technology within mental health policy. For example, in one of our recently published peer-reviewed papers, we analyzed the priority given to technology in 22 mental health policy documents collected from Canadian provinces and territories that were published until 2019. Each of these documents described a vision, a strategy, an update, or an action plan for improving mental health care within their jurisdictions. We figured that mental health and addictions policy documents represent the highest level of priorities for a government's vision and strategy for a mental health care system, and as such would be a primordial place to make the case for the role of technology to improve access to services. We found that, however, that when the documents mentioned technology, they most often were referring to low tech, such as phone services, helplines, and very few mentioned technologies that are mainstream, such as apps, or increasingly becoming mainstream, such as virtual reality. We also found that there was limited strategic focus and guidance, and this I think is the most important point of the review, limited strategic focus and guidance in how to implement technology within the mental health care system, and that technology in many cases seemed to play a more tokenistic role in these policy documents. Next slide. In contrast, the important impact that policy has had in advancing the delivery of mental health services is well illustrated by the example of Australia, that is often seen as a leader in the delivery of digital mental health services. And in part, their advancement, I would say, is due to strategic policy leadership. So for example, in 2012, almost a decade ago, the Australian government's Department of Health and Aging produced a policy document entitled E-Mental Health Strategy for Australia. This document provided a vision for e-mental health service for the country and key areas for action. It also provided guidance on investment, guidance on development to advance the field. The document was produced through the input of several different types of stakeholder groups. So, if there is a takeaway message to what I'm saying, it's the following. I believe it is important for the role of technology to be very clear, comprehensive, and I would argue that in this day and age, also very central to any federal, provincial, regional, and organizational documents describing vision, strategy, mission for the mental health care system. To be truly transformative versus tokenistic, such policy needs to account for technology infrastructure, privacy and security regulation, capacity building. By that I mean training of future healthcare professionals, as well as skills upgrade for the current ones, equity, diversity, evidence, agility, and integration of technology into hybrid models of care that are based on patient needs. It is also important to ensure that we are thinking about the role of technology within a continuum of services, from referral to appropriate care and across the different levels of care. So, in conclusion, leveraging technology to improve access and quality of mental health and addiction services is a global priority. It was a global priority before the pandemic, given the gap in access to services, and will be an even dire priority post-COVID-19 pandemic, given the additional mental health impacts of the pandemic itself. to shift that priority into a reality for Canadians, we need leadership that is visionary, coordinated, concerted at the level of mental health policy, specifically in terms of the role that technology can play in improving access and quality of mental health services for Canadians. And this can be supported through initiatives that bring together different stakeholder groups, including policymakers, researchers, practitioners, and consumer representatives. And finally, I've listed a few papers here because they are written particularly with healthcare leaders and policy makers in mind, and which go into more detail and beyond what I've talked about today. And to learn more about our work and this topic, feel free to contact us. Thank you very much for your attention.
Thank you, Dr. Lal. That's a great overview and gives us some ideas of context as we move along, and we'll come back to you, I'm sure, with some questions a bit later on. I will turn it over to Dr. Steve Mathias to speak to us about what it's been like to deliver virtual and in-person services in a provincial model of care called Foundry.
Thank you for that, and we'll jump right in. So my name is Steve Mathias, and for those of you who don't know who I am the executive director of Foundry, which is an organization, a program of Providence Healthcare in British Columbia. And we are extremely well supported by not only our host organization, Providence Healthcare, our philanthropic organization, St. Paul's Foundation, but also by the Ministry of Mental Health and Addictions, the Ministry of Health, and other government ministries in British Columbia. And we've been in existence now since 2015, and our brand, Foundry, was launched in 2016. And really our attempt and our goal is to transform the way young people access mental health and substance use and other health and social services by the creation of initially centers in various communities across British Columbia, and more recently by the addition of virtual services. Currently, we have 11 centers open, and we have 8 more that are on the drawing board and will be open either at the end of this year or next year. And we also have a virtual care service that provides care to young people in British Columbia, and I'll get into those details in just a little bit. Foundry is really intended to be a co-op. So it's not meant to create a new silo. If anything, it's really intended to break down silos. And so all our centers invite organizations, services that exist in the communities to come together and create a location that is readily accessible and advertised to young people and family members. And our population of interest, the young people we try to support, are between the ages of 12 to 24. And so with the declaration of the global pandemic back in March, really, of 2020, we realized as an organization that had 11 centers open, where face-to-face service was the norm, that we really needed to pivot and pivot rapidly. And so in early April 2020, we launched Foundry Virtual BC, which began offering services to young people and caregivers across British Columbia. So really beyond the communities where our centers existed. And we first began that service with clinicians, counselors, peer support workers who were working in our centers. And then with the support of government, we were able to pivot and create our own workforce. And from that process, we're a year down the road now with lots of lessons learned, and we will be sharing those lessons learned today. I just want to thank Frame for supporting the evaluation that has gone into the presentation today. And just to also want to acknowledge with gratitude that I'm coming to you today from the unceded ancestral territories of the Coast Salish people, Squamish, Musqueam, and Tsleil-Waututh First Nations. So next slide, please. So our first learning is that provincial virtual services really started to fill a gap for youth and their families. And so you've just heard Shalini. So we go back quite a long ways. Dr. Lal and I back to when she was still what we would say a student. And so it's a real pleasure to follow you today. I just wanted to highlight that for us, what we wanted to do was fill the gap that we just spoke about, the gap really that exists for young people and family members who aren't able to access in-person services. And that was a problem that existed well before the pandemic. We know that there's a gap in terms of accessing care, and we recognize that there was a comfort level as well that came with accessing virtual services. And so in our first year and a bit of operations, so 13 months, we have provided virtual care to over 1,600 young people, accessing over 3,900 services. And we've also managed to provide care to families and caregivers as well. So those are parents who are struggling and looking for support. And we've been able to support over 200 of family and caregivers in an area for us that I would consider an area of growth. When we have surveyed young people, and this is a small sample size, but 40% of the young people we surveyed talked about how they felt more comfortable accessing services virtually than in a physical center. That's a considerable number, 40%. And that while a small number chose Foundry services because of the COVID pandemic, a lot of young people just indicated they had nowhere to go and nowhere else to go for services, and that they either physically or for whatever reason, it might be work or school related, couldn't access services in person. So the ability to have more flexible service delivery, I think, is something to really keep in mind when you shift to virtual services. Next slide, please. Our second learning is that the development of an app can really change the way services are delivered. And so when we started and we launched this back in March of 2020, we were doing it using the Microsoft Teams platform. We were scrambling to figure out how to deliver the service. We landed on Microsoft Teams. But in the background, and this was obviously by coincidence, but recognizing that we would want to shift to a technology like an app, we had been working on, in partnership with the government, the development of the Foundry BC app. And this was a process that had started almost 5 years ago and had really gathered steam and momentum in the last two and a half years prior to the pandemic, thanks in no small part to the Ministry of Mental Health and Addictions and their leadership around this app. And so while it took several months to get the app finalized, the pandemic really accelerated that work. And we were able to launch that this year at the end of February. And by March 1st, we were starting to see young people register using the app, which is a end-to-end solution when it comes to accessing counseling virtually. And so since March 1st, which is just over 2.5 months now, we've had over 1,400 young people register and download the app. We've had over 1,600 youth appointments completed through the app, with another 200 appointments waiting to be completed. And those appointments can be booked online where young people can self-schedule, which again is breaking down a barrier that typically exists when youth are, I would say, more typically reliant on the availability of the clinician, whereas this model will really allow us to open up the availability for solution-focused brief therapy, which is what is being provided on the main by this app. We've also seen lots of care providers using the app and getting comfortable with accessing care through a virtual platform. Next slide, please. So the public launch of the Foundry app didn't happen until just a couple of weeks ago. And we saw a huge surge, a significant surge for us in terms of the number of downloads when that happened. We had 200 youth register during a 3-day post-announcement blip. And we saw 10 times more traffic to our website following the government announcement, with over 20 media articles and stories run in either paper media or on the news. And so it was really quite a significant jump for us in terms of interest, and we've continued to see that grow since the announcement. Next slide. This is an example of the timeline of our virtual care and what things have looked like since we launched virtual care in April. And so this was almost a year ago now. And you can see along the way how certain improvements in our services really lead to increments in young people accessing our care. So we started off with just drop-in counseling, and then in May, June, you saw another bump as we added peer support. And then again in September, we actually were able to provide online booking. So whereas before young people had to call in using a 1-800 number, we were able to move over to an online booking system. And then in January, our services were expanded, our hours were expanded. And then in March, our Foundry BC app was actually launched. And again, we saw an increase in service access, but in a lot of the registrations that we had, and that's the purple line. We had a near tripling of registrations in that period of time. Next slide. So right now, our breakdown of services is predominantly walk-in counseling and youth peer support. We're increasingly providing groups that provide mental health and substance use supports, as well as specialized population. So we have a really active LGBTQ2S population on one of our groups. And more we're adding sexual health and primary care resources. So this pie chart will really shift over the coming year as we're able to add more and more services. And one that we're really proud of is the addition of employment support. So for those occupational therapists in the crowd, we're adopting a individual placement and support model. So that will be really helpful for young people who want to re-enter the workforce. We're also really excited that young people are accessing more than one service. And that's really what you're wanting to do with this type of virtual care model, so that that stigma is removed from multiple services. So as many as 7 services have been accessed by the same youth. Next slide. So one of the things I want to highlight is that young people who are using this are coming in with high levels of distress. Over 92% score on the K10, which is a distress scale, are as either distressed or highly distressed. And we also find that 86% of young people who are accessing our service identify as having fair or poor mental health when they access our virtual services. So we really feel like this is actually, this profile is more distressed with a lower rating of mental health than it is for the young people accessing our centers thus far. So it's significant that we're seeing young people who really do need help. And I think that when we start talking to young people about how they, what they're feeling and what they're struggling with, I think their stories really resonate for all of us. And it's important to recognize that I think our philosophy is to have as many access points as possible for young people coming in, and eventually trying to find services that can really address those with more moderate to severe mental illness. Next slide. When we continue with our youth experience survey, it's pretty unanimous that they have found this to be quite easy to access. This model has been co-designed by young people. The technology has been co-designed by young people. And so the young people are quite satisfied with their experience. And they really appreciate that the hours of operation that we have are accessible to them. And so 7 days a week, 1 to 9 p.m. every day. And then one last slide, please. We have to acknowledge, too, that there's lots of lessons learned. One is that while young people may have access to smartphones, they often struggle to find a space that is suitable for their appointment, a safe space in their home or school or place of work. So we often find ourselves talking to young people while they're walking in the park, because that's the safest space that they can find. And so that's just something to remind everyone that it's not obvious that there's a safe space for people to have those conversations. Some folks really struggle to access resources, and so peer support for us really helps young people navigate to those resources that are close to them in their communities. This is a reminder for all of us that about 10% of our young people, and this has been consistent over the years, still are not satisfied with how much we're involving their care providers or their family members. So it's always something to keep in mind. And then obviously we have some lessons learned if we go back in time as well. Last slide, please. I just want to thank, obviously, all the donors and the key funders that we have who've contributed to the development of the app, as well as our virtual care program. If you're interested in just a quick 1.5-minute video of how it works, please click on the link there, or go back and get the link when you listen to the webinar again. If you have any questions, please feel free to email us as well. I think that's it. Thanks, Elena.
Thanks, Steve. And we'll be sure to share out that link when we send out the follow-up material and the link to the webinar so that people don't have to listen from the beginning to get the link. So we'll be sure to include that. And thanks, Steve, for sharing some of your experience with the app and virtual care. I'm now going to turn it over to Daphne Hutt-McLeod, who's going to tell us more about her experience with both virtual and in-person services, really, I think, from a First Nations perspective in Eskasoni. So thanks, Daphne, for being here.
Thank you for having me. Good afternoon, everyone. As Alana mentioned, I'm calling you or on the Zoom line from Eskasoni First Nation in beautiful Cape Breton Island, Nova Scotia. Eskasoni is also one of 16 access open mind sites across Canada. So for some of you who know a little bit about Eskasoni, we have a philosophy here that it is our responsibility as a mental health organization to provide mental health and mental wellness services for the entire community, both those who are in need of specialized mental health services, but also the community as a whole to be able to keep people healthy and well. With COVID, with the situation with COVID, it definitely put that philosophy to the test because we had 48 hours notice that our community was going into a total lockdown, which included requiring special travel permits to enter and exit the community. So we had 48 hours to prepare. Regrettably, our community, like many other Indigenous communities, is accustomed to crisis situations, and that has honed our ability to pivot, maneuver, and navigate storms and crisis situations. So as a result, COVID-19 was just one of those situations to be met head-on and dealt with. So what did we do when COVID hit? So like most places, our clinicians immediately went to offering virtual therapy sessions. But we also realized that we had to provide services to a broader community. We had a community that was in lockdown and without special permission could not enter or exit the community. So we had to create a whole series of things to be able to keep people at peace and try and keep them entertained. So some of the things that we did was we created an online mental health video series on such topics as depression, anxiety, grief, how to deal with stress. We also created a lot of home packages for youth and families because we wanted to be able to make sure that they had arts and crafts materials to be able to keep themselves busy because for the most part, they weren't allowed out of their own homes or their properties. We also created and distributed flyers and supportive documentation regarding coping skills, how to deal with, stress, worry, anxiety, as well as COVID educational materials because we needed to be able to translate some of those medical terms into words that would be easily digestible by youth and by people with a second language, with English as a second language. Our staff also tried to attempt to address and manage the emerging COVID-19 related impacts, such as food insecurity, access to prescription medications, groceries, and delivery of essential items during community lockdown. And if nothing else, COVID has taught us that mental health is not separate from anything else. It's not separate from health. It's not separate from the food you eat. It's not separate from the house you live in or the shelter you have over your head. It's all interconnected. And our staff were at the forefront of being able to provide some of these necessary sustenance items. Our Access, Open Minds, youth peer support workers all felt that because they were young and healthy, that it was incumbent upon them and their responsibility to take care of those community members who are less fortunate. So one of the key elements that they provided during the lockdown was they delivered for 10 weeks, they delivered 200 food baskets once a week to food insecure households. They also shopped for groceries and made deliveries to community elders. All of our youth programming went virtual and included contests, competitions, tournaments, arts, crafts, cooking challenges, educational, mental health, educational, and public health educational videos. Everything we did on our online work switched from being youth focused to family focused because we wanted to keep people occupied as a family unit. Throughout the 3 waves of the pandemic, communication with community members was essential, but it was also challenging. Lack of internet in this area was a big challenge. Overcrowding in households with no privacy to be able to conduct a counseling session. The lack of technological devices prevented most of the marginalized clients from easily accessing clinical services. So to help address that, we relied on outreach services. We installed landlines in a safe, secure area for clients to be able to come in and meet with their clinician because they didn't have a phone or they didn't have a home. We also used every possible mechanism we could to communicate with people, whether it was the community TV station, social media accounts. We even sent out pieces of paper so they could put it on their doors if they needed help. Being only one of 10 sites in the community with Bell Fiber Op, we also provided the community with our Wi-Fi password and provided socially distanced picnic tables so that youth could complete their online homework and community members could communicate and remain updated. And in order to create something positive amidst the despair and the worry, our staff worked on a memorial garden for missing, murdered Indigenous women and girls. It was supposed to last 2 years, but we completed most of it in 4 months. And I would really encourage you to take a peek at our video, which is highlighted on the slide in front of you. We were also really proud of being able to launch the IYS Graham Beck Foundation Bell video just prior to our Wave 2. Would you be able to move to the next slide? I included this next slide to give you some idea of the amount of interaction we had with the community over the past year through our Eskazoni Access Youth Space Facebook page. Please understand that when you're looking at these numbers, we only have about 4,900 people living in this community. So the stats, the graph that you're seeing up there can be somewhat impressive. Next slide. Her. I thought it might be interesting to show you the amount of, and most of this graph is online or virtual, but the way that the graph goes almost aligns and mirrors the flow of our waves 1, 2, and in the next month or so, we'll see whether or not it reflects in our wave 3. So during the period where we had wave 1, we had the most amount of clients, and then wave 2 hit us in November, and we went back up again, and now we're entering wave 3 and our worst wave, so it'll be interesting to see what happens. Last PowerPoint, please. So I was asked to talk about whether or not we believed that what things would look like post-COVID in regard to virtual therapy. I mean, certainly COVID moved the implementation timeline of virtual therapy ahead, which is a terrific advancement. It provides clients and clinicians with yet another tool in their clinical tool belt for providing accessible services. Virtual therapy is definitely convenient for some clients because of their presenting issues, whether it's social anxiety or anxiety, their inability to access transportation. It also is convenient for those with work and or schedule or school conflicts and those who have childcare issues. Will we continue to use it in the future? Most definitely, but it will never replace in-person therapy. Not every person or client has access to, nor can they afford the technology required to be able to engage in this. The technology, like for instance, very few people had internet here. It draws a socioeconomic line in the ground for many people. Specific clients and specific treatments require in-person services, especially for those who are high at risk. Difficult to maintain focus with young clients. One of our clinicians ended up getting the inside view of a toilet when one of her young clients dropped her mother's iPhone into the toilet while showing her the new renovations. So there's also humorous moments. Clinicians are also reporting that they are emotionally and physically exhausted from conducting back-to-back virtual sessions. They report it requires more intense focus because they're not being able to pick up on some nonverbal cues and behaviors, and they find it's very stressful to try to fill the silences. They also feel like sometimes they're missing something because the person's not right in front of them. Far too much of what we do is based on human connection, building relationships and social interactions. A virtual hug will never be able to replace a real hug. It's really difficult to give somebody a virtual Kleenex to wipe away their tears. And next, we miss our clients and they miss us, plain and simple. We are incredibly social down here in the East. Thank you very much for providing me with this opportunity.
Thank you, Daphne. And I'm sure we're all looking forward to the day when we can give people a hug virtually. So I know for some people in different parts of the country, that's happening sooner than later. Over to you, David, to share some of the lessons learned from IAPT and where you're headed and how you're thinking about virtual care post-COVID-19.
Great. So thank you very much, Alana, and it's a great pleasure to join you all this afternoon. And my apologies for having sent the wrong set of slides. You would all be asleep if we'd gone through those because they were for a much longer talk. But I'll whiz through a short talk. So I'd like to tell you a little bit about what's been happening in England with what we call the Improving Access to Psychological Therapies, or IAPT program, how it's tried, just like you have, to adapt to COVID, and many similar lessons, I think, to the ones we've just heard, actually, and some thoughts about where we're going in the future, which I think will also be quite similar to what we've just heard. Next slide, please. So what is IAPT? Well, it's a large and very transparent public program to deliver evidence-based psychological therapies for depression and anxiety. One of its key features, because it's quite an investment, is to try and collect outcome data on everyone who has a course of treatment. And we do succeed in doing that. So we managed to get pre and post-treatment measures of anxiety and depression on 99% of everyone who we see at least twice. This is very different from the rest of mental health in England, where in community mental health or children and young people's services or perinatal services, you can see the outcome collection rate is much, much lower. We treat about 610,000 people a year. So since our first lockdown of COVID, which is now 15 months ago, we have treated remotely 820,000 people. And the outcomes that we get in the IAPT program are more or less in line with what you'd expect from the research literature on CBT, interpersonal therapy, counselling, things like that, which is what we offer. So 51% of patients fully recover. They drop out of the clinical range for anxiety and depression, and 68% of people show substantial improvements. And the general model, with lots of differences, of course, is starting to be used elsewhere. And of course, Ontario is one lovely example with the structured psychotherapy program, which we're following very closely. Next slide, please. So IAPT, of course, wasn't included in anyone's pandemic planning. And as you had to do, we had to move to remote delivery of the treatment very quickly. In a period of 3 weeks, really, we moved all of our therapists to deliver treatment from home by video link or telephone or online programs. But we also had to make sure that we could continue to collect all the outcome data, which was critical. So we created a phone app that allowed patients to input all of their data on their phone in response to an SMS link. And we did a very large online training program of webinars to help train our therapists in how to deliver treatment remotely. Next slide, please. And you can see some of the topics that we covered. They were very popular, the webinars, so we had up to 1,800 live participants per webinar and about 4,000 for each webinar when you look at looking at recordings afterwards. The first was to persuade people to keep the services open, and then we went for some of the more tricky things to deal with online. So how do you do PTSD treatment when you have to get people to process very traumatic memories, but you're doing it remotely and you're not there in the room with them, but doing it with a video link? And we created lots of short videos to show people how to do it. And you can access some of those free from our website that's mentioned on the bottom right-hand side of the slide. But over time, we covered all of the main conditions dealt with in IAPT, including a special seminar on traumatic grief, because it was obvious that we're getting a lot of that from the very large number of people who've died from COVID in very difficult circumstances in England. Next slide, please. So this shows you the shift in the medium of delivery of therapy over time. So our lockdown started at the end of March last year. So you can see that video was really a very small component of delivery pre-COVID, but it's now increased by 1,000%. We did do a fair amount of therapy on the telephone, and that increased as well, but not by obviously such a large percentage. We've been using online therapy programs for a while, but they didn't actually take up much more capacity. It was much more the therapist remotely connecting with people. And as you can see, face-to-face just collapsed from 64% of all sessions down to just 3%. Next slide, please. And this shows the activity each month. So the first thing you'll notice is referrals. So when the nation went into lockdown, a lot of people's mind was on how to stay safe when we have a deathly virus circulating at very high levels. And so actually referrals went down quite a lot, and GP practices weren't open either. But they recovered quite quickly after a few months. But the key thing I'd like to illustrate is the grey line, which is the number of people who had a course of treatment. And you can see that stayed constant throughout the pandemic. We were able to continue to live as many courses of therapy remotely as we had before. Next slide, please. And of course, the key issue is, yes, but did people get better when we did this shift? Because it was fairly unknown territory for us. And thankfully, we found that we were able to maintain our outcomes. So on this slide, the red line is the national target for recovery, 50%, and we were at it just before the lockdown. Then in March and April, when we got our first lockdown, you see we dropped just a little bit below the target, mainly I think because people were moving all the computer equipment and things to home and trying getting organized for delivery. But we soon went back up to our pre-COVID levels, and we stayed that way up to the latest data we have, which is February this year. And you can see the improvement rates show a very similar pattern. This was really encouraging. So we were finding we can do just as well with remote delivery as we were before. Next slide, please. But we are finding that the cases that are coming in for treatment during COVID are considerably more severe and considerably more complex. And we've responded to that by increasing the average number of sessions that people get. And that's probably one reason why we've managed to continue to get as many people to recover. It's interesting that the workforce has been able to deliver more therapy sessions remotely, and it's probably because the therapists aren't traveling between different sites during the day and have more time to just focus on delivering the therapy remotely. Next, please. We've also discovered some interesting points. So this looks at the rate on the left-hand side of people who didn't turn up for an appointment and didn't warn you in advance, what we call DNAs. And you can see that for video, it's a very low rate, about 3 to 4%. For telephone and previously for face-to-face, it's higher, 6 to 7%. So it does seem as though for a video call, people are, maybe they don't have to travel to get, but when we've talked to patients, they say, but I can't really not connect because I know there's someone waiting on the other end and I can see them in my mind's eye. I've seen them before. So we get very good attendance on the video calls. We have found that this remote data entry has worked incredibly well. And we find that the SMS texts are the most effective way of getting people to do it. And we get very quick responses with that. So we're going to stick with the phone input of data rather than any questionnaires. Next slide, please. So what do we think we've learned? Well, we think we have learned that remote delivery does work, and it is very likely to be a prominent feature of our delivery system in the future. It has some big advantages to staff. It allows much more flexible working. It's easier for therapists to deliver some sessions in the evenings. They can also juggle around childcare in the way they're delivering therapy, and they're not wasting time traveling to centres. And for some patients, it's more convenient because of the not having to travel to places and the greater flexibility about when they can be seen. We do think we need to shift the balance more to video rather than phone, because some of our therapies, like the PTSD treatment, the treatments of social anxiety, really do not work well enough unless it's a video link. And in the video platforms that we use, it's very important that you can set them up so you can have whiteboards to draw things on. You can set it up so you can still see the emotional response of your patients, and also that we can do behavioral experiments in sessions. So we also use mobile phones to send patients out to do an experiment, and as we stay connected and observe what happens for some things in anxiety. And we've also learned that remote data collection is viable, and actually it means that we don't waste any clinical time on collecting data, so it gives us more therapy time. So these are all great things, and I've put out there a recent reference which shows you there is a meta-analysis of video delivery showing on average it is as effective as face-to-face, and at least with CBT the effect sizes are very large. With some other therapies that it doesn't seem to do quite so well, which is a bit of a problem for us because we cover a range of therapies. Next slide, please. However, just as Daphne said, we are very clear that we also need to return to face-to-face therapy. And there are many reasons for this. Firstly, actually, a substantial number of patients refused remote therapy. They were scheduled in for face-to-face, and they said, can I wait until we get out of the lockdown and I'll come back for face-to-face? So they weren't served well. We also find that some people really don't have a home setting where they can have a therapy session while feeling secure. They don't have a room of their own. They don't feel safe in their own home, or they don't have a good enough internet connection. We've also done a survey of all those people who went through remote therapy and asked them, if you came back again, would you be happy to have the remote therapy again, or would you like face-to-face? And these are people who've done very well with remote therapy. And a very high proportion have said, well, but if I had the choice, I would like face-to-face. And so we think that patients must have a choice when it is possible for them to travel. Of course, when it's not, they can't. So that is going to be a mandate that we will require patients to be able to have the choice of either delivery system. For therapists, if you're not in for a day or so in the week in a clinic, you don't necessarily get such good support from your colleagues. You don't get those social interactions which boost your own confidence. And it's difficult to do some of our clinical supervision and governance. We like to record some therapy sessions and review them with therapists, and we haven't quite got the governance around that for the remote delivery yet. So some of our commissioners have said, well, maybe we can get rid of some of our offices and things, get rid of some expensive estates and run everything remotely. Our official government messages do not do that. Remote delivery will be a much more prominent part of the future. But as we're still trying to expand our services, we don't want you to reduce your capacity to deliver face-to-face. Next slide, please. And that's it. Thank you so much for listening.
Thank you very much, David. As usual, I think there's lots we can learn from the UK for the Canadian context. I am very conscious that there's lots of people who have joined us today who have lots of experience delivering services, developing policies to deliver services both in person and virtually, and probably have experiences or lessons learned that they too would like to share. So feel free to write those in. If you want to make a comment, feel free to let us know, and we will do our best to try to get to as many of those. I'm going to now turn it over to the panelists. I have a few questions, but I would also encourage all of you to write in your questions so that we can take some of them. I'm conscious we may not get to all of them, but we'll try to get to as many as possible. And one of the questions I have for the panelists is, I think you've offered us some really good ideas. I think it's clear from the presentations that nobody is advocating for only virtual or only in person. But I'm wondering, given that the primary audience of this webinar was really aimed at policymakers, and I'm conscious we have lots of different stakeholders and partners here, so thanks for being with us. But I am curious from the panel's perspective, what advice do you have for policymakers on how to create effective and integrated virtual and in-person mental health care services? Any advice for policymakers?
Well, my advice would be to say, whatever you do, make sure you collect the outcome data, because we don't know exactly what's the best way to do it. And so if you don't collect the outcome data on all the patients as you go through the services, you can't really judge how things are going. And I think that's been the key lesson of that, because we do get outcome data on everyone. When we go into these uncharted territories, we can see whether it's working out or not, and sometimes it doesn't. But in this case, the remote delivery that we were using did seem to work very well, and as a consequence, we will be investing a lot more in the future. But I think you can't just rely on research studies and then assume that whatever you got in a research study will be implemented equally effectively in routine practice. So routine outcome monitoring and report is the critical thing, I think, for commissioning, because it allows you to adjust your commissioning based on what you find.
Shalini and Steve, I see you nodding your heads. Anything you want to add?
I would really just echo what David just said. Evaluation is really, really important. Just because it's we know something from research doesn't mean then we go ahead and apply it. It's important to have an evaluation process, especially because this is still relatively new. People are doing different things in different contexts. So I think evaluation is really, really important. I think stakeholder engagement as well. Ensuring that you have the different perspectives at the table when you are in the process of developing policy in this area. So researchers, practitioners, consumer representatives, families, community organizations, technology partners as well in this space. I'll just pause there for now.
Thanks. I'm also conscious, and David shared some results in terms of how services, how some services may be better than others. And I guess I'm just wondering if anyone from the Canadian context can speak to some lessons learned you had around if there are particular services that you think are better, better offered in person or better offered virtually, and how you've seen that play out. David, do you want to maybe expand on some of what you've seen as to what services might be better in person or virtually in the UK context?
Well, I can tell you the group of patients who have not been very keen to have remote therapy and have really put themselves on the waiting list to be seen first as we open up, and that's people with obsessive compulsive disorder. And for the sort of CBT for that, which often involves doing some, challenging things with the therapist in the therapy session, they have a strong preference to coming back to face-to-face. But interestingly, if we take some of our most severe people with social anxiety, starting off remotely seems to work very well for them, as long as you make sure that in the video link they can't see a picture of themselves, because then that makes them incredibly self-conscious. So the setup I have at the moment would be a nightmare for someone with social anxiety. So we get them to put post-it stickers over the image of themselves, so they're not self-conscious, and it seems to work quite well. A lot of our therapists have been very anxious about doing some of the PTSD treatment, particularly with highly traumatized individuals. But we found that it actually works very well. But in order to teach people how to do it, we've had to release an awful lot of video clips illustrating how to do it while staying, empathic and in the moment with people and managing risks. But you can see some of those on the clip on our website. We've got about 50 very short video clips of how to do these different things. And we've had a lot of feedback from patients about, what they found good on video and what they didn't like on video.
I'll add to David's comment that it's really important to keep in mind that, whether you use clients or consumer, that there is a consumer preference model that starts to emerge out of this type of work. So there will be certainly certain presentations or certain folks who really do need to be seen in person. And I would say that, there's going to be other, because it's therapeutic to be seen in person for them. And then there's other folks who are okay to do this virtually. And there's some people who are going to be a combination of both based on not only their preference in the moment, but also the circumstances that they find themselves in. And so I think that we have to really be careful that we don't have a binary conversation around this, because the future is not binary. The future is really, hey, I'm running late for my appointment. Can I see you virtually? I tried to make it down and the bus broke down, so I'm just going to see you using my technology. Or, hey, I dropped in today. I know we were planning on virtual, but something really came up and I really wanted to speak to you in person. And I think that if we have that kind of flexibility, one, we will have far more capacity in our system. There's no doubt that we will have a lot more capacity to deal with it. And two, I think that we'll have people engaging far more because they feel like the system responds to their needs. And I think that's really critical. I also want to highlight too that one of the themes that's kind of emerging out of this is that we're not over therapeuticizing our clients. We are making the right level of care available to them. And I know Peter Cornish is on this call, so I know that he's a big believer in step care. And I think that's something that we also have to make sure we do, is that we have solution-focused brief therapy, 1 or 2 sessions, which are strength-based and are readily available for folks, so that they're not scrambling and really struggling to access, say, 8 to 10 sessions with a therapist 6 to 8 months from now. So I think that we just recognize that this is just one more way of providing services to folks. And we don't want to get into, like I said, a binary conversation around which one's better or best.
Daphne?
And I just want to keep it at the forefront that there is a large population of young people who cannot afford the technology, nor do they have the access to hotspots and whatnot. And in many cases, they have some of the highest needs. And this is, as I mentioned in the presentation, this really does put a line in the sand regarding your wealth and your socioeconomic status. So I think it's an amazing opportunity to be able to do this, but I would really be cautious about not being able to provide services to some of the less vulnerable or some of the more vulnerable populations that we serve.
Yeah, and I know in other contexts that it's been very clear that conversations around access to internet and broadband can't be separated out from the conversation around virtual mental health care, because it is so, especially in rural and remote parts of the country, it really isn't two separate conversations. It needs to be part of the same conversation.
No, our clinicians, while we were in lockdown, all of us were writing proposals madly to be able to get the technology, to be able to pay for the technology, to be able to distribute within the community.
So I think the other theme that I've seen really come through this conversation so far is really the focus on clinicians and the importance and the role that clinicians are playing in being able to shift. I'm conscious that many of the clinicians haven't necessarily been trained in providing care online and virtual care. And I'm wondering if any of you can speak to what type of training, might need to be added to curriculum, what type of training might need to be offered, as well as how do we help ensure the well-being of clinicians in a world that is constantly evolving, and maybe, Steve, to your point, be balancing both in-person and virtual care. Have any of you developed some curriculum on that, or given some thought to how we might train clinicians to work in these new ways? David?
Well, we developed this sort of webinar series that seemed to go very well, and lots of short video clips. And I think, the feedback from our clinicians was very good on that. In terms of the well-being of the clinicians, we found that it was really important to schedule sort of team meetings which weren't supervision but were a bit more social, that still brought people together as a community, even if it was going to be on Teams or Zoom or whatever. And we also found that it was very important to continue people being able to attend professional development training and things remotely. There was a real risk that everything would be just devoted to delivering endless therapy without that support. And I think we would have had terrible problems with staff well-being if we'd done that. So these things are all very important if you do it remotely. I think, could I also say something to commissioners who might be listening? So Steve has emphasized that patient choice is very important here. The patients should have a choice between, face-to-face and remote delivery. The research also shows that patient choice is very important in psychotherapies. In general, you do better when you get the psychotherapy that you had a strong preference for. But unless you get the commissioning right, people won't have a choice. So we've had the problem that some services have thought they're so keen to go to remote delivery that they're adjusting almost all their capacity for that. And then effectively patients would have to wait longer for face-to-face, so they lose their choice. So we're now requiring all services to actually measure their waiting times for both streams, face-to-face and remote, and ensure that they're comparable, because otherwise you take choice away from patients.
Shalini, I think you wanted to add something.
Yeah, no, I mean, I would just agree as well with the importance of choice and preference, and that people's choice and preference changes over time too. So what they may decide initially may not necessarily be how they feel later on. I think it's important not to categorize populations in relation to, for this population, virtual health service is really good, and for that population, not so good, because there is a lot of variation in populations, right? So oftentimes, for example, I work a lot with individuals who have psychosis, and I'll get this comment that, oh no, for people with psychosis, they're already paranoid about this and that. We don't want to put them on video, or we don't want to do this and that. That's going to just worsen or exacerbate their symptoms. And that may be true in certain cases, but it's important that we don't sort of, apply a kind of a label on a particular health issue and say, for that particular health issue, it's not. I think it really comes back to choice of the participant, preference of that person, and also their context. And so as Daphne was also highlighting, people may or may not have access to certain things, even if it was their choice or their preference. to come back to the education training question, Ed Mantler mentioned in the chat, and I want to just highlight that comment. The Mental Health Commission of Canada has done a great job, and I don't work for the Mental Health Commission of Canada, but so just to say that, just my observations, has done a great job in terms of developing different sorts of tools and resources, and sort of catalyzing that conversation around the importance of technology and virtual mental health services. So if people are interested and are less aware, I encourage you to check out their website, and they have a section called e-mental health, and you'll be able to see the various things they've been working on. Myself, in the last about 5 or 6 years ago, I initiated a course. I teach in the School of Rehabilitation, so I initiated a course that introduces rehabilitation students on the topic of e-health, and that includes e-mental health, or the use of technology in the area of mental health services. And we tried to break it down into different sorts of modules, and it's not a very easy course to teach, because in the 5 to 6 years, you can see what I was talking about even 5, 6 years ago has changed a little bit in terms of what I'm talking about now. So for example, more recently, I'm incorporating the themes of artificial intelligence, where I was not really talking as much about that initially. I'm talking a lot more about virtual reality and its role in, phobias, and that was not necessarily something I was doing initially. A core part, one sort of module, or just to give you an example of a type of topic we go through, is we help healthcare students to understand better, how to evaluate apps. How do you know if an app is a good app, or how do you know if an app is a bad app? Because of the sort of, I call it the epidemic, the mania in the development of apps, it's going to be very, very difficult to sort of say, okay, here are 10 apps that are great, because this is going to be changing year by year. So I think that healthcare professionals need to have some basic understanding of how they should go about looking at an app or a digital tool or a digital resource or a website, and understanding, how to sort of to determine if that's something that they should be recommending to their clients. And my final point about that is that course is not part of the core curriculum. It's an optional course. So in a school of, let's say, 500 students per year, only about 30 to 40 students in that year are going to get access to that content. And the feedback I get from students is, why is this the case? Why do I have to option into this course as an elective? Why is it not part of my core curriculum, a course that content that all of us are exposed to? So that's, I would be advocating for this to really be looked at the core curriculum aspect of nursing students, occupational therapists, medical students, psychologists, social workers, the long gamut.
Thanks. And I see there are a couple of questions that both tie into the private sector. And so one of the questions has to do with how are you dealing with collecting information privacy issues related to virtual sessions, especially if you're using third-party apps. And then there's another question around the private sector and the fact that more and more private sector organizations and companies are developing platforms for mental health care, apps for mental health care, and the person asking the question is curious what the panelist thinks on the private sector moving in, and how they might be able to work with public sector and community sector. So I'm just wondering if anyone on the panel wants to address either of those questions before we wrap up.
I'll highlight, and I sent this in the chat, but I'll highlight that by working with our government to develop this app, I think that there are fewer concerns in our neck of the woods, and this is certainly we've had conversations within our working group about how we share this out to other jurisdictions in Canada, because the app has had just so much work put into it that I think it would be a real shame if it wasn't, made available as a white label product. So something that can be really defined by the jurisdiction where it's in. But I think that that's the kind of thing that we really have to think about in Canada is what are some of the resources that are in a repository that can be shared out. And what are those lessons learned so that because it is an incredible amount of money to invest. And as I said, it was a 4-year process for us. So I don't know of too many places that have access to that kind of funding and the time to do it. So It's just something to, I think that we all just have to recognize is that the at some point you reach app saturation, and I think we're way past that point, and you have to really kind of think about what are the apps that are most suitable for the environment you're in. One last thing I'll just say too is for those, and I think about what your comments are, Daphne, for those folks who are in environments or in communities where not everyone has a smartphone or no one has a smartphone, the question is, can we set up hubs or hotspots where young people can go and safely access that kind of counseling, virtual counseling service without fear of a family member walking in? So whether it's a it's a broom closet in a school that's converted, or it's a small vacant shop in a shopping mall that then has spaces for young people to use. I think we really need to think about how we can make virtual care more accessible for youth in ways that we haven't done in the past.
And I guess I'm going to go back to what Andre had said earlier in reference to why do we have to have different platforms in different provinces? Why spend so much money developing something, reinventing it, and it's only slightly different in Nova Scotia as to what it is in Montreal, as to what it is in BC? Should we not use our money a little bit more wisely and develop something that is a national set of protocols, platforms, data collection? I look to Australia and the way that they're doing things, and I honestly believe that we in Canada are capable of doing the same thing, and it would all that money that's being replicated over and over and over again would be better served creating one system that is utilized by all of us. But that's just, and then maybe we'd have a little bit more money to put on clinicians and stuff.
Thanks. I'm going to just ask if Shalini and David have any last comments, maybe just in 30 seconds before we wrap up. Anything else you want to share?
Well, I think Daphne's last point was a very good one. And in terms of data collection, I mean, the IAT system is actually very cheap. We have a sort of bespoke system for collecting the data from the services, and everyone uses, and it goes straight into government processing, covering the whole country. And it's a very modest cost.
And I'm sure, David, if people want to follow up with you, I know you're always welcome to sharing lessons learned. So,
sure.
Shalini, anything else?
Just a ditto support with what Daphne was saying. I think maybe it's an area where policy research, initiatives can also, like some kind of funding initiatives that can support the use of, okay, well, here's something really potentially interesting, evidence-based, there's a lot of momentum going on here. How can we scale this up to other parts of the country? I think it could be an area that policy can be thinking about. And just to give you a small example with one of my experiences, a number of years back, I was naive. I wanted to develop a kind of a platform for young people recovering from psychosis. And fortunately, I did a bit of environmental scan before actually trying to develop something on my own, and found something that was developed in Australia. And I said, well, this looks really promising. Maybe instead of trying to develop it, I could enter into partnership, and we can now try to adapt it and evaluate it for the Canadian context. But there was no funding for that. I actually got funding from the US to take this platform that was developed in Australia and bring it to Canada. And only after about 5 years of kind of working in this area did I finally get money from CIHR to scale it up in Canada. So I think if there were sort of policy kind of funding, implementation initiatives that would support this kind of work so it can actually move faster, that would be a good thing.
So Daphne, 30 seconds. Oh, you're on mute.
last comment is COVID-19 has taught the entire world that we can do things faster and better when we all come together. And we can do it in lickety-split time. So I think we all collectively make a decision and we just go and do it.
Thanks, Daphne. And I think, I see one comment from Marianique at Health Canada who wanted to, I think we're talking about what's happening at pan-Canadian scale, and I know that Health Canada and the federal government have set up Wellness Together Canada, and I'm sure there's keen interest to work with all of the provincial initiatives and work that people have talked about on this conversation. So that's another opportunity at a pan-Canadian scale. I think what I did want to share, just in reflecting, there were a few things that I kept hearing time and time again through this conversation. I think just to remember as we depart, 4 of those things I wanted to share. I think as we're talking about virtual and in-person care, especially in the virtual space, it's important to remember that the person who's seeking care needs a safe and secure space to access that care, and that isn't always obvious. So how do we create that? That moving forward, we're going to need to continue to create opportunities for both in-person and virtual. And we really want to create a seamless, fluid transition between those and most importantly, allow client choice in the matter and as well as clinician choice and ensuring that both clients and clinicians are best able to choose and access services in the way they want. And then I think also important as we think about the future, what I heard strongly was to remember that not everyone has equal access to technology and internet and equal opportunity to access the services. So how do we build that into the strategy and direction that we want to go? And so on that note, I really want to thank our panelists and our speakers for being so generous with sharing your knowledge and your lessons learned. I want to thank all the participants for joining us today and for sticking with us. We will be following up with an email with a brief evaluation this afternoon. So please fill it out. It helps us inform where we go and what we do with future webinars, because as you know, we have hosted several of these and hope to continue to do so. And then we will be following up in due course with a copy of this webinar and any additional material that the panelists want to share with you. So thank you very much. Merci beaucoup. Je vous souhaite une très bonne journée. À la prochaine.
Thank you.
Thank you. Bye.
Thank you.
Thank you.